Okay, I'm going to go ahead and start this PowerPoint. So this will be your Module 6 Neurologic Disorders PowerPoint. So we're going to start with ALS, so amyotrophic lateral sclerosis. This is also known as, maybe some of you have heard, Lou Gehrig's disease. This is a neurological disorder that is fatal. It's a CNS disease that is rapidly progressing and causes a gradual degeneration and death of motor neurons. Um, it, like I said, it is fatal and ends up affecting voluntary muscle control. So with ALS, this affects both the upper and lower neurons, which by affecting them, it causes this wasting to occur and this atrophy to happen. And the neurons end up dying, and then the muscle becomes very, very wasted. So the muscles weaken and atrophy, and then start this twitching that can occur. The brain loses its ability to initiate and control any of the muscle movement, and patients will become paralyzed. But the big thing with ALS is that as this this process continues, and they eventually cannot move anything, it does not impair their senses or their ability to think. So the brain will end up losing control or its ability to control any muscle movements, and the symptoms progress, and to the point where it does become fatal. But the patient themselves have full cognition and awareness of everything and has full sensation. So manifestations of ALS, like I already said, typically there's this upper spasticity that occurs, and then a lower extremity flaccidness that happens. So patients may initially complain of like muscle cramps or stiffness and weakness, and then it'll continue to progress, and they'll start having this weakness and atrophy in other parts of the body. As the disease continues to progress, obviously they're going to end up losing control and the ability to protect their airway. So it's very important for, teaching family members to watch for this when this starts to occur. Um, since they're unable to control over their muscles and their movement, it's important to know that they may not have the muscles available to even present with tachypnea. So we would be watching for um, signs of hypoxia, like dusky skin and things like that. And then, of course, teaching the family members to watch for that. So treatment with ALS is therefore, since it's a progressive fatal disease, the treatment is symptomatic relief. A lot of times, maybe they would be prescribing um, antispasmodics like baclofen and things like that for muscle cramps, or stool softeners and laxatives for constipation that may be happening. They can put these patients on CNS stimulants like antiepileptics and tricyclic depressants, things like that. Maybe atropine to help with excessive salivation. In your book, there's examples of medications that they use to treat ALS. And then, just like I said, as the disease progresses and the muscles weaken, then obviously assistive and breathing devices, if the patient chooses, may be used. Nutrition is very important, and a lot of times patients with ALS do start to lose weight. So gastric feedings may need to be initiated for them to meet nutritional requirements. And then if they end up choosing mechanical ventilation, then sometimes patients with ALS then would need to have a tracheotomy done and have a trach for long-term effects of ventilation. So with this progressive disease that leads to the inability to move, then obviously a complication of complications that can occur because of their inability to move is very important. So, watching their skin integrity on these patients and making sure that they're getting turned and having vigilant skincare is very, very important. Also, complications start to arise because of aspiration of food and fluids. A lot of times that can lead to pneumonia, respiratory failure. These patients can also end up getting DVTs and pulmonary embolisms. So the list just kind of goes on and on. So, again, with airway, because of the motor weakness involved with the muscles of the face, the mouth, the neck, all of that, maintaining an intact airway that becomes very compromised. Um, so watching for any impaired airway or anything showing airway compromise is extremely important. So watching, like I said, for like dusky skin tones would be important. Um, Obviously, we would want to be doing range of motion and turn, cough, deep breathing as much as possible. It's important to have these clients on a schedule for turns, making sure we're turning them every 2 hours because of that massively increased risk for impaired skin integrity because of being so immobile. So it's very important to educate that to family as well to make sure that repositioning is done because they cannot move anything. So it's very, very important. And then to remember that their sensation is still intact. So it does not impair their senses or their ability to think. So on this slide, here is a video. It's not that long, maybe 6, 7 minutes, but I would highly recommend you watching that video. In the um, notes section, it has the link. If that link doesn't work, it has the URL that you can copy and then put into another window and watch the video. And it's of a patient that has ALS. Very, very good video. Okay, we'll move on to Guillain-Barré syndrome. Guillain-Barré syndrome is a disorder that's an inflammatory demyelinating disorder of the peripheral system. This is sparked by a immune response to a viral or bacterial infection. So it usually occurs after an infection, and what happens is a rapidly progressing flaccid paralysis then ensues. Um, So manifestations of Guillain-Barré is you will have this symmetrical ascending motor weakness. So it starts at like the feet and then it moves up. So it ascends up the body. So a symmetrical ascending motor weakness and paralysis that usually starts in the feet and extends to the trunk and the arms. Patients may complain of having paresthesia or numbness and tingling, and they will end up having diminished or even absent reflexes. Uh, Up to 40% of patients that have Guillain-Barré can develop into a respiratory impairment. So, when that occurs, this respiratory failure is caused by weakness of the diaphragm and the intercostal muscles. And a lot of times when that starts to happen, then the patient will need to be intubated and put on mechanical ventilation for respiratory support. Do know this also, the patient's level of consciousness and cognitive function remain intact through the entire process. So they can hear everything, sense everything, as far as, or not sense, but like hear everything. They're conscious and they're cognitively aware of what's going on, even though they're paralyzed. So the pattern of recovery then for Guillain-Barré is the reverse of onset, and the nerves that were affected last are the first to improve. So, as it ascended up the body to cause the paralysis, then once the recovery starts, then it descends down the body. So, that's kind of how that happens. Diagnosis, is a lot of times they'll do a lumbar puncture and look for elevated protein. They'll talk about, the progression of the disease process and what's going on. And if there was a history of some type of recent viral or bacterial infection. And then another thing that they can do is an EMG or an electromyography, and that's used to diagnose GBS. This shows nerve conduction, and so it'll show a slowed nerve conduction velocity soon after the client develops paralysis. And also in the speaker notes on here is another link that you can go to and watch a video. It's real quick on what an EMG looks like when somebody's having that done. So there's a couple approaches for treatment as far as treatment modalities for GBS, and pretty much they center around IVIG and plasmapheresis. So, it kind of your speaker notes will talk about both of those and what's involved with the IVIG and how that, when if it's caught, if this GBS is caught, um, in a certain time frame, then using IVIG works for them. And then they also go in to talk about plasmapheresis and say that if the treatment is started within like 2 weeks of the onset of neuropathic manifestations, then this works best for them. So you can read more about both of those and how those work with Guillain-Barré. Obviously, if we're having an ascending weakness and paralysis, then it would be important to watch diet. So a lot of times when you have problems, that are happening where you have this weakness that's happening, it can be eating and swallowing things just fine one day, and then the next day maybe it progresses up a little bit and you start having some dysphagia. So you need to really get speech therapists involved, so they can be doing um, constant swallow evaluations to see if there's any problems with dysphagia that's happening. And if you are the nurse of these patients and um, everything's going fine with taking their medications 1 minute, and then the next day you come and you work another shift and you notice that the patient's starting to having difficulty swallowing pills or water and they're coughing and things like that. This is something that needs to be reported immediately to the provider, not only because they could be aspirating, but obviously we could have a progression of the disease and maybe they need to look at going on a mechanical ventilation. Okay, so failure, skin issues, and then because of being immobile, then DVTs. So patients with GBS, the respiratory status is constantly monitored as far as breath sounds and how well they're doing. They'll do vital capacity tests on these patients every 12 hours to see if they're still able to pull certain volumes with their lungs. And if that starts to decrease, then we are able to catch that. And if we need to ventilate a patient because of the compromise to that, then we can do that. So we would be definitely watching the airway, making sure that's maintained, and then intubating and putting these patients on mechanical ventilation if needed. Again, if we are taking care of a patient and they start showing signs and symptoms of respiratory compromise, like maybe an increased uh, use of accessory muscles or something like that, that would be very concerning and would make us think that they were having a worsening of their respiratory status. And this would be something that we would have to report. Okay, our next we're going to talk about myasthenia gravis. So this is an autoimmune disorder, and basically it results in the body's immune system attacking healthy cells. Um, there's um, there's a direct link to antibodies that are formed, and these antibodies then go after the acetylcholine receptors um, within the muscle fiber and the cells. And when it attacks this acetylcholine receptors, um, messing with that whole process, then the skeletal muscle ends up having a weakness and a fatigue that happens. So with myasthenia gravis, it's like I said, it's a um, autoimmune disorder where it affects the acetylcholine um, synapses that happen within the muscle cell. And this motor disorder is characterized by localized skeletal muscle weakness and fatigue. So the antibodies bind to the acetylcholine receptors and cause this dysfunction. As far as clinical manifestations, um, these can be displayed as ocular, bulbar, or generalized. So ocular clinical manifestations happens with 2/3 of the patients. This a lot of times they'll have a ptosis or a diplopia that occurs. Bulbar or muscles and nerves that are used for speech and swallowing. This happens about 16% of patients and will affect their chewing and swallowing. And then general manifestations. This comes in about 16 to 20% of patients. They'll have weakness that occurs with their muscles, difficulty with ADLs. So a lot of times when they have this trunk weakness and these limb weaknesses, these are the common symptoms that patients will go into the emergency room with seeking medical attention. Okay, trigeminal neuralgia. This is affects cranial nerve number 5. So this slide just kind of shows that there's like 3 branches of cranial nerve 5, the trigeminal nerve, and it kind of shows how it goes to the ophthalmic area, then the maxillary and the mandibular branches. So you can see how if you have uh, some neuralgia that's happening with that trigeminal nerve, how it can affect in different areas within the face. So trigeminal neuralgia is a pain disorder, and obviously patients will come into the ER or to their PCPs seeking attention for pain relief. They'll have this very sudden, severe, stabbing, reoccurring facial pain. The etiology is unknown, or what's causing it, or what's causing this vascular compression. Sometimes it can be from a tumor. Sometimes, it could be from a virus. So it's like a constant burning sensation that covers your face. I actually get some trigeminal neuralgia that occurs to me, and it seems to be if I feel under the weather or something, or have maybe a viral infection, run a fever or something, then occasionally, about a week after that, I'll start getting a tingling sensation, typically on the right side of my face, and it can increase to pretty severe, intense pain until that calms down. Okay. So, diagnosis then, therefore, is clinical presentation and ruling out other processes like maybe a direct injury to the fifth cranial nerve or tumors or anything like that. Um, they can do MRIs, they can do lab work um, to see what's going on with that. Some of the medications that can be used to treat trigeminal neuralgia can include anti-epileptic drugs like AEDs like carbamazepine or gabapentin. Um, this could also help with pain relief. Usually, they say that opioids are not effective in treating neuropathic pain, so they don't typically um, prescribe that. A lot of times, medications do not help, and sometimes patients will seek out a um, some type of surgery that could help with the relief of that. So they can do microvascular decompression. That's the most effective surgical treatment for this disorder. And a lot of times they can have relief pretty quickly from that. Some non-pharmacological strategies would be anything that help with reduce stress. So meditation would help, diversional activities, acupuncture. They also say to avoid things exacerbating factors like cold air or drafts. A lot of times the pain can be so severe that it does interfere with activities of daily life, and it can start to affect the patient's quality of life. Okay. Um, Brain tumors. You don't need to know all these areas of the brain where the brain tumors are at, but this slide just kind of shows um, that the location of the brain where the tumor is located kind of dictates what type of tumor it is. So, kind of says here, like if you have gliomas, that these are in the frontal lobes, meningiomas, therefore, up here, you can see at the top of the head there that they're in the meninge area. And then it goes on and on to talk about pituitary tumors and acoustic neuromas and so forth. Um, Typically, brain tumors are metastasized most commonly from lung, melanoma, renal, breast, and colorectal cancer. So, some clinical manifestations, just like I said, depends on the location of the lesion. And the most important thing would be to be watching for signs and symptoms of increased intracranial pressure. So, depending where the tumor is at, um, would then determine the pressure where the pressure on the certain lobes of the brain are going to occur. So, a lot of times you can have cranial nerve compression from these tumors, where they put pressure on the lobes and cause a swelling, or they can have a rapid growth of the tumor, therefore increasing intracranial pressure or ICP. So, some symptoms of that would be headache. Headache is a symptom of increased ICP. Um, Papilledema, which is a swelling that can occur of the optic disc. So, symptoms of that would be like a flickering or blurred vision or diplopia or double vision, nausea and vomiting, obviously decreased level of consciousness, hemiparesis, seizures, vertigo, dysphagia. All of these things would be important to teach patients and families, especially if they've been diagnosed with a brain tumor, um, these signs and symptoms, so that way they would know if they were having increased intracranial pressure and could notify their provider immediately. This next slide, I couldn't decide if I should take that out or not. I think that quiz, that Guillain-Barré quiz link is the quiz you guys do in your modules, so you don't need to do that. But there's also a quiz, a brain tumor quiz there that you can go to and test yourself. This goes straight to your FA Davis. So your Davis Advantage. So you have to make sure when you click on that link that you have your Davis Advantage already open. Okay, so we talked a little bit already about increased intracranial pressure or ICP. So this Monroe Kelly doctrine just kind of talks about how your skull, you can see there it says it's comprised, 80% of it is brain, and then only 10% is blood, and 10% is cerebral spinal fluid. So you can see that there's not much room there for any type of swelling at all. Um, Basically, the Monroe Kelly doctrine says when one element increases, the others must decrease. So the body just does what it needs to do to address levels of this component. So the way uh, it does go on to talk in your speaker notes, it says brain tissue is composed, like I said, mostly of water. It makes up about 80%. The most common initial method of intracranial compression involves the displacement of cerebral spinal fluid from the cranial vault down through the foramen magnum of the base of the skull and around the spinal cord. So when you have this loss of intracranial compliance, this leads to cerebral herniation syndrome. And we're going to be talking about that more as we continue. This is when the brain tissue is displaced, and if the displacement is not resolved or stopped, the brain stem then becomes compressed, and this eventually leads to brain death. So you can see how this is vital that this process, if we have any type of increased ICP, that this is taken care of immediately. So increased ICP is detected by performing serial neurological assessments. So you will see anything dealing with the brain, your interventions are going to be serial neurological assessments like Q1 hour. So not only does this include things like eye opening and awareness, cranial nerves and motor function, but we should also, besides just asking them basic, you know, questions like, where are you at? What's your name? What time is it? But include more specific things like, if you say, where are you? And they say, I'm in the hospital, then maybe I would go on to say, what floor are you on and what unit are you on? And why did you come to the hospital? What was going on with you? Ask more in-depth questioning is basically what I'm trying to get at. So the most sensitive indicator of increased ICP is a decrease in level of consciousness. So this has to be the very first thing that you're seeing, which is why you're doing serial or Q1 hour neural assessments. A lot of time, the clinical presentation of increased ICP can be very subtle, especially in the early stages. And then once you have that cerebral herniation, then you have this sharp contrast in presentation. But unfortunately, once you have cerebral herniation, then you're too late. So the clinical manifestations of increased ICP need to be detected very early, and treatment needs to be implemented swiftly, very early, to prevent herniation syndrome. Um, and then you'll also find out as we keep going that there's also changes in vital signs. People will talk about Cushing's triad, and we'll talk about that. By the time that's happening, it's too late and herniation has already occurred. So that's a late sign. Things like blown pupils, um, the process is already done. Okay, so here's some different areas of the brain that can show cerebral herniation, and is classified according to the region of the brain that is displaced. So you can see here, like central herniation, where that would take place right in the center there, and uncal herniation. So it just depends on where that's happening within the brain. Um, as we talk about like central herniation and uncal herniation, you're going to see that you can have this posturing that happens. This is an abnormal flexor or extensor of movements that is observed with the upper extremities and the lower extremities. And this is not a good sign. So the first person there, it shows decorticate posturing. And the way I remember that is your hands are brought inward to your core. So that's decorticate. At least, at least the patient, even though it shows massive deterioration, this is not good. But they're at least trying to protect their core, I guess. And then you have decerebrate posturing, which the arms are down to the side and then turned out. They're not even protecting their core here. So this is definitely the worst type of posturing. They're both bad though. So central herniation occurs when certain structures like the thalamus or pituitary gland, um, when you're having problems with that, and then the temporal lobes of the brain are displaced in a downward direction. Um, this then pushes the brain through the tentorium and therefore compressing the brainstem. So with central herniation, you will see this posturing that occurs. You can see bilateral pupil dilation or blown pupils, positive Babinski reflex, coma, and then it talks about Cushing's triad. So Cushing's triad is when you have a widening pulse pressure. So if you take your systolic blood pressure and then you have your diastolic blood pressure, if those differences, if you have an increasing systolic blood pressure and a decreasing diastolic blood pressure, that is called a widening pulse pressure. So that's part of Cushing's triad, is that widening pulse pressure, and then bradycardia, irregular respiratory pattern, or Cheyne-Stokes breathing. In uncal herniation, you have the tip of the temporal lobe shifting and inward and going toward the midbrain, and then again through the tentorium and compressing cranial nerve 3. Now, cranial nerve 3 is innervated by the parasympathetic nervous system, and this is what the stimulation causes pupil constriction. So compressing that cranial nerve then causes pupil dilation and the inability for the pupils to constrict. So that's how you get fixed and dilated pupils. So with this uncal herniation, you can have a unilateral pupil dilation. Again, positive Babinski reflex, posturing here, and coma. Okay, so with all this talk of ICP, it's important to start talking about intracranial pressure monitoring. This is done with a catheter or a sensor, and they put it in like the ventricle of the brain or the parenchyma or the subarachnoid space. So with this intracranial pressure monitoring, um, we can trend how the patient's responding to medical treatment. We can see if our ICP is increasing or decreasing. Um, so this is a way of watching our ICP. Another thing we can do with ICP is we can give medications. So um, we talk a little bit about osmotic diuretics, or mannitol is our osmotic diuretic that we use to give patients if they have increased ICP. It pulls the fluid out of the brain into the vasculature, and you then diurese it out. So it is used, like I said, to pull the blood, or I'm sorry, to pull fluid out of the brain. interstitial space, and then by doing that, that decreases volume or ICP. Then there is this diuresis that occurs. Other physical interventions that we can do is raising the head of the bed. This decreases ICP just by gravity. We can hyperventilate. So hyperventilation is something that they can do. This decreases ICP by inducing hypocapnia, so blowing off your CO2. This causes vasoconstriction, and when you have vasoconstriction, then you have decreased blood flow in the brain, therefore decreasing the pressure in the brain. They can also try draining off the cerebral spinal fluid. So this is done when they place an IVC catheter or an intraventricular catheter. Then they can connect this to a external ventricular drainage system or a ventriculostomy. So they would use an IVC or an intraventricular catheter connected to this drainage system. And this is how, by raising and lowering the collection bag, they can drain off cerebral spinal fluid or stop draining cerebral spinal fluid. They can also do a surgery, like a removing part of the cranium to create a space for the swelling of the brain. That would decrease ICP as well. Okay, so here's some different nursing diagnosis. A lot of them are self-explanatory, but ineffective airway clearance because of diminished protective reflexes like cough and gag, ineffective breathing due to neurological dysfunction, that brainstem compression, ineffective cerebral tissue perfusion because of cerebral edema or hemorrhage or hydrocephalus that's occurring. You can have the fluid volume deficit also because of the osmotic diuretic administration, ineffective thermoregulation because of maybe damage to your hypothalamus. So kind of on and on here. Nursing interventions, like I've said, hopefully by the time of this video ends, maybe I'll say it 10 times. Serial neurological assessments, because another 10 times I'm going to say that change in LOC is one of the earliest signs of increased intracranial pressure. So they're going to be doing these Q1 hour or Q2 hour neuro exams. With this, obviously, vital signs to detect any type of hemodynamic and neural instability or decline, especially like if you have herniation, which would be bad because you're too late now, but that's Cushing's triad. Temperature, we've already kind of talked about that. Every 1 to 2 hours, you'd be watching that because you could be having hypothalamus damage. Fevers actually create increased oxygen demand in the brain, so we want to watch that. Maybe they'd be monitoring intracranial pressures or cerebral perfusion pressures every 1 to 2 hours, and then doing what they need to do when they need to do it quickly to intervene. There's this release of catecholamines that happen because of the stimulation of the nervous system. So brain injury can cause that. So watching cardiac rhythm, because of this. Release of catecholamines is important because you could have cardiac injury due to that. So watching their cardiac rhythm and biomarkers like troponin, CKMBs, things like that. INO because of the osmotic diuresis that can occur. Watching serum sodium. uh, They really do watch this. Low serum sodium can actually cause fluid shifts in from the extracellular compartments into the brain and can lead to cause cerebral edema or swelling within the brain. So they do not like hyponatremia at all. And then watching your CO2 levels, doing ABGs, or maybe monitoring an end tidal CO2. Again, maintaining the head of bed at greater than 30 degrees or semi-Fowlers is very important for decreasing ICP. And then keeping when it says optimizing positioning, they need to keep the head midline in a neutral position. When you turn the head from side to side, you actually increase ICP. Also avoiding hip flexion. Flexing the hips will increase ICP. With ET tube suctioning, we only do it if it's necessary because that increases ICP. Sedatives are used to help maintain or decrease ICP. I already talked about mannitol using osmotic diuresing, and that is the most effective diuretic for decreasing ICP. And then also cooling measures to decrease cerebral metabolism. That helps. And then we already talked about cerebral spinal fluid, maintaining that drainage if needed, if they institute it. Okay, so there's a lot of different tubes that they use and devices that they use during the course of treating increased ICP, from central lines to ICP monitoring devices, ET tubes, gastric tubes, anything like that to help manage patients that have increased ICP. We've pretty much talked about medications. We would want to definitely talk to patients and teach them about all of this. So that it's very important to be compliant with their medications. We talked about bowel regimens, that they should be on stool softeners. Maybe they would have a helmet if they had a craniotomy. Um, Make sure it's fitted, that, teach that they wear it whenever they're out of bed to prevent injury. We definitely, when we're educating our patient, we want to make sure that they are alert and oriented. That's even more so important because of what's going on with this. We're talking about, the head and trauma or increased ICP that can cause confusion. So make sure your patient is alert and oriented. We would want to teach the patient and family to report signs and symptoms. I talked before about um, a diet to promote good bowel regimen and to report like signs and symptoms of a headache or things like that. Okay, and then this is just a kind of a recap slide. So cerebral herniation syndromes, we said, are classified as according to what region of the tissue that's displaced. And some of the most often recognized signs of a cerebral herniation are what you see with Cushing's triad. So you have that increased systolic blood pressure with a decreased diastolic blood pressure, or that's called widening pulse pressure. along with bradycardia, and then that irregular respiratory pattern or chain stroke breathing. You can also have posturing, we talked about, a positive Babinski reflex. Sometimes they can have unilateral dilated pupils or even bilateral dilated pupils. All of these fixed and dilated, doesn't have to be both of them, it can be just one. Those are all signs of high ICP or increased ICP. This would be the herniations. So this would be very, very bad. Okay. Now we're going to kind of get into stroke. So with stroke, this is basically saying that there's a disruption in blood flow to the brain. This can be from a blockage of a blood vessel, which would be an ischemic stroke, or you can have bleeding that's occurring in the brain, and this would be a hemorrhagic stroke. As you can see there on this slide, ischemic strokes account for 87% of strokes. It's dramatically more than stroke, which is only 13%. There's your it says in intracerebral hematoma, which is ICH, or subarachnoid hemorrhage, which is SAH, just so you're aware. So there are screening tools that they do that they utilize for stroke. It's the NIH stroke scale or the NIHSS. Here's a link, and then also in the speaker notes is the URL, so you can look at that and familiarize yourself with that screening tool. Here's a video that you can watch. Right here is a link. Stroke, simply put. Again, the URL is in the speaker notes, but this just kind of shows the development of a blood clot that occurs with atherosclerotic plaque, and how it can cause this development of plaque and disruption with the blood flow in the artery. Okay, risk factors, there's a lot. You guys can read those, but hypertension, diabetes, smoking. Obviously, with these risk factors, early treatment is very important. So people that have hypertension, getting them to get their blood pressure under control, maintaining their blood glucose within an expected range, maintaining a healthy weight, getting exercise, all of these are important to help offset these risk factors that can lead to a stroke. So ischemic stroke is a sudden blockage of cerebral blood vessel, which reduces oxygen. This will lead to an area of brain tissue that can suffer irreversible damage or an infarction. So anything that causes this critically narrowing of the vessel, therefore obstructing blood flow. Okay. So diagnosis of this is done using a couple of different things. The most important there is CT scan. So this is done right away when they call a code stroke. This is done immediately, and it's done to differentiate between a hemorrhagic stroke and an ischemic stroke. Obviously, if we need to know what the difference is because of how we're going to treat them. So it is imperative that we find out right away from a CT scan to differentiate between hemorrhagic and ischemic causes of stroke. They can also do MRIs. Other things that they do are Doppler ultrasounds or carotid duplex scannings to see if there's some type of stenosis or occlusion. They can do echocardiograms to see what the heart function looks like. Um, lab work. There's another chart in your book that kind of goes over those different diagnostic tools. So medications for our thrombotic ischemic stroke is going to be the most important one is IV recombinant tissue plasminogen activator. You can also call it TPA. This is your clot buster. So it allows blood clot to be dissolved at the site and restores blood flow to the ischemic tissue. It's indicated, as I said, for ischemic stroke. Patients must present within 3 hours of symptoms, and in some cases, they can give them up to 4.5 hours or 4.5 hours. Their risk receiving this type of thrombolytic is obviously bleeding. So if there's any risk of bleeding or they've had any type of um, bleeding that's just happened recently, like a GI bleed or a head bleed or anything like that, they're not going to be able to get TPA. So no TPA if there was a head injury like in the last month. Um, Other than that, other medications that they use are DVT prophylaxis, management of blood pressure, antiplatelet therapy, lipid lowering therapy, and then anticoagulation if they end up having AFib. So they do 12 leads on these patients to see if they have AFib that's been undiagnosed. So make sure that you look in your book for inclusion and exclusion criteria. So again, TPA, if there's any type of bleeding, then they are not going to administer TPA. So this chart, table 39.8 in your book came straight out of your book. This kind of goes over some of the exclusion criteria, and really the exclusion criteria is what's going to be the most important, because if any of that is occurring and you give TPA, then we can obviously cause injury or death to our patient. So things like, as you read down there, your exclusion criteria, head trauma, GI bleed, it says here, so that like recent, looking for it. There it is. Any type of active internal bleeding, gastrointestinal or urinary bleeding within the last 21 days, or known bleeding risk, including but not limited to. Then it goes on to talk about platelet counts less than 100,000. If they've had a heparin drip in the last 48 hours, an elevated PTT, like you guys can read through this. Major surgery in the last 14 days, recent stroke or serious head trauma, intracranial surgery in the last 3 months. They've had spinal surgery, if they've had a history of a hemorrhagic stroke. There's your blood pressure. Oh, recent lumbar puncture in the last 7 days. Here's your systolic blood pressure greater than 185 or a diastolic blood pressure greater than 110 at the time of administration of TPA. So what they do if your blood pressure is out of those parameters, then they'll give you medication like nicardipine or something like that to lower your blood pressure. And then once your blood pressure is lowered, then they'll give you the TPA while you're on the nicardipine. Anyway, you guys can read that. Another thing, it says there that a last known well time. So when they talk about, um, making sure that a person, what we ne- when we say last known well time, so like, if a patient was in the hospital and up on a med surge floor and they went to bed at 10 o'clock, or we'll say 9 o'clock in the evening, that's the last time the nurse checked on the patient, they were fine, and then they go, they sleep all night. Right? 6 o'clock comes, the nurse goes in there to see the patient again before going home for the day, and they're unresponsive. So their last known well time was 9 o'clock at night, and now they're being assessed at 6 o'clock in the morning. So that's what, 9 hours. So they do not get TPA done. So that's why they need to know, when was their last known well time. That will exclude them. Okay. Some acute complications that can happen, are cerebral edema. You can have increased ICP. Um, this cerebral herniation syndrome. And then obviously aspiration is a huge chronic, complication that can occur. This goes on to talk about obviously weakness or paralysis. You can have neglect or, inattention to, the paralyzed side, visual field deficits. I was just trying to remember how to say that word. Homonymous hemianopia. Homonymous hemianopia is a visual field defect where you have vision loss on the same side of the visual field in both eyes. So, this can occur from a stroke where, and affect an entire side of vision. So patients with this type of visual field deficit, they need to learn, like if it's on their right side on both eyes that they cannot see, they have this vision loss, then they need to learn, scanning techniques so they can make sure that they can see an entire visual field, so they don't have injury. So, for example, to make sure, like a patient eats everything on their meal tray, they have to take their head and turn it, completely to scan the entire space to make sure and compensate for that darkened or absent field of vision. So like if they're walking, before they start walking, they have to turn and scan the entire room because of that visual deficit, that visual loss that's occurring on the same side, in of the vision field in both eyes. So that's, see, now I can't say it. Homonymous hemianopia. Homonymous hemianopia. God, that is a hard word. Okay. And then, as we keep going, obviously disorders of speech because of facial muscles that can be affected. Um, and it just goes on and on here. So they can have depression. So all of this are chronic things that can happen, and it just affects their entire ADLs, their life. So, here's an acronym that, is used to help with stroke awareness. We call it BFAST. This is a service announcement to help the lay people understand, certain symptoms, that could be stroke. That way they can get into the hospital and get treated. So BFAST, the acronym to help detect and enhance responsiveness to an individual having a stroke. So the This stands for balance, eyes, face, arms, speech, and time. So balance, sudden loss of balance, eyes, sudden loss or blurred vision, face, smile, does one side droop, arms, it says raise both arms, does one drift down, speech, difficulty speaking or understanding, and then time, it says call 911 if you see any of these signs. So be fast. Balance, eyes, face, arms, speech, and time. All right, subarachnoid hemorrhage. Just basically, this is if you, like if you would have a rupture of an aneurysm, if you have a bleed in your head. So, like I said earlier, small percentage of this says it makes up about 5% of all strokes. Unfortunately, this is a high mortality rate for patients that have hemorrhage. And it says here about 10 to 15% of these patients die prior to even reaching medical care. And the mortality for patients treated in the hospital is about 50%. So not good. Some of the risk factors for subarachnoid hemorrhage are hypertension, smoking, drinking, obviously cocaine use, history of a CVA, and that kind of sucks. Female, that does suck. That puts us in another category. God, and then postmenopausal. This is depressing. Okay, traumatic brain injury. Traumatic brain injury, you can have an open head injury where the skull is compromised, like if you have a penetrating object or a blunt force trauma. You can have a closed head injury. Again, this can be from some sort of blunt trauma that happens, like if there's a deceleration and the head hits something. It can be mild, moderate, severe, and then it just depends on how our Glasgow Coma scale pans out when we use it and the length of time the patient was unconscious. Here, this just kind of shows it's kind of some of the pathophys. Um, you have that primary injury where the head, you have the acceleration, deceleration that happens. So the head goes forward and then the brain's going backwards, and then the brain goes forward as the head goes backwards. So you have that coup, counter coup movement there. And it can cause the shearing and twisting that happens within the brain inside the head. Some signs that you can see here. This is just kind of shows when you have these basilar skull fractures that happen from this. It shows the raccoon eyes or battle sign. Here's your Glasgow Coma scale. So the lowest you can get here is a 3. And looks like the highest you can get is a 15. So even if I had, they say less than 8 intubate, a score of an 8, you can see like, let's see here, I could have an eye-opening response only to pain, and then inappropriate words and flexion. You see that flexion there under motor response, that's your posturing. So you can think that 8's pretty good, but 8 is not good on a Glasgow coma. They say less than 8 intubate. That makes sense. Okay, this slide, we're just kind of talking about contusion. This is when you have a superficial bleeding that occurs on the surface of the brain. Um, This is usually because of the initial impact or the coup that happens. A concussion or a mild TBI, head trauma. This usually, it says, occurs after head trauma that results in change in the client's neurofunction, but no identifiable brain damage. So they have a concussion. So usually resolved in 72 hours. Here's a video you can watch on TBI. Want to talk a little bit about the neurons and what you can see with shearing in the neurons or post-traumatic condition of a neuron as a result of um, having this injury from severe head trauma. So the neuronal injury, a lot of times that can happen during head trauma. And this is something that it's not easy to see this neuronal damage with CT or MRI. A lot of times they'll do more advanced diagnostic scanning to see what the neuronal injury is. And then vascular injury. So with a traumatic subarachnoid hemorrhage, um, you can have this vascular injury that happens and you end up having layering of blood in the arachnoid layer. This causes this traumatic subarachnoid hemorrhage can occur due to disruption of veins and arteries within the brain. So here, this just kind of shows the different, what do I want to say, levels or areas of like the skull down to the dura mater on into the brain. You can see the different levels there. So you can have intracranial hemorrhage that can occur epidural, subdural, or intra cerebral space. So you just got to kind of watch that. Um, and where the disruption of the veins or arteries are occurring. So traumatic injuries, usually accidents like motor vehicle crashes, um, drug use, alcohol use can cause this, sports injuries, obviously falls, gunshots, assault. Um, Here again, there's a video that's implanted into this slide on decorticate and decerebrate posturing. But anytime you have this type of hemorrhage happening or traumatic brain injury, you can have amnesia, loss of consciousness. Obviously, we talked about cerebral spinal fluid leaking. Um, if that's happening at all, if it's leaking from the nose or the ears, if you had basilar or skull fractures, then you just take 2x2s and lightly tape them over the nair or over the ear to collect that drainage. And that way you can send it down to the lab and see if it is cerebral spinal fluid. Manifestations, this goes into manifestations of increased ICP again. We've already covered that. Some therapeutic procedures that they can do here. So a craniotomy that can be done to relieve ICP. They open the skull up and maybe they need to do a craniotomy to remove non-viable brain tissue. Maybe they need to do it because there's a subdural hematoma. Maybe to decrease ICP, or it's done for brain tumors. They can do these drill these burr holes into the skull. They can then put in IVC and then hook it up to a drain and drain off cerebral spinal fluid. They can do a bone flap. We already talked about mannitol. So obviously, potential complications, brain herniation, edema, cerebral edema, increased ICP, all of this kind of makes sense here. DI or SIADH, especially if the pituitary gland is disrupted in the brain. Obviously, we'd want to monitor our electrolytes and osmolality. So subdural hematoma is collection of blood beneath the dura and above the arachnoid level or layer. So this is typically caused from damage to a vein is what can cause a subdural hematoma. So it's typically because of damage to a vein where you get this collection of blood. Then when we go on to epidural hematoma, the blood collects in the space between the inside of the skull and the dura. So it's deeper there. And this pushes the dura further away from the skull. And because of you have this pushing and displacing of the dura, um, it displaces structures laterally, so it has this convex appearance. So if you have an epidural hematoma, you get this convex appearance. So it also says that this is the talk and die phenomenon. So patients with epidural hematomas can initially like lose consciousness and then regain consciousness again and appear to be pretty lucid and then just rapidly deteriorate, become unresponsive, and actually have this cerebral herniation syndrome that occurs. So because of that, they call it the talk and die phenomenon with an epidural hematoma. And it's because of this rapid deterioration that can happen because this is typically an arterial damage. So you have this rapid accumulation of blood in the epidural space, and this is a neurological emergency that has to be immediately surgically evacuated. This hematoma does because it's an arterial damage. And you have to do surgery. It's the only option. Again, ad nauseum, serial neurological assessments every 1 to 2 hours during this so we can see if there's a change in their LOC. And then, it kind of goes on to talk about, again, and I've already talked about it, ECG and cardiac biomarkers, vital signs, seizure activity. We've already kind of talked about nursing intervention. We've said raising the head of the bed greater than 30 degrees, having the head midline, avoiding hip flexion, managing CSF leaks. One thing you need to do is talks about avoiding nasogastric tube placement. This is in patients that have known basilar skull fractures, where the base of the skull can't be visualized, or in patients where the base of the skull can't be visualized, because you could put an NG tube in and cause more disruption, actually put the patient at risk for the tube to go up into the brain. So instead of doing an NG tube, a lot of times they'll do an orogastric tube placement. We've already talked about some of these manifestations that you may see, but bradycardia, hypotension, change in LOC, and a metabolic acidosis. Now with neurogenic shock. So neurogenic shock is a distributive type of shock. This causes massive vasodilation. And when you have this vasodilation, that's what puts it into the distributive shock category. So you have vasodilation, and this is relative hypovolemia. So you don't really have hypovolemia, but because of this vasodilation, it makes the body think that it has like a hypovolemia. And this is what neurogenic shock is. This causes a hypoperfusion. It's a disruption in the sympathetic nervous system, and it causes an inability of vascular smooth muscle to constrict, resulting in decreased blood return to the heart, decreased cardiac output. So you have a sympathetic nervous system interruption, and then with unopposed parasympathetic nervous system action. Because of this, you may get a transient profound bradycardia in some patients, not all of them, but in some. That's the big difference with neurogenic shock, is that bradycardia. All of your other shocks will have tach. So treatment is correcting whatever the primary cause of this neurogenic shock is. That's the way you manage this. And then treating hypotension and bradycardia. So we would definitely do fluid resuscitation, crystalloids. This would help increase cardiac output. Vasoactive are pressors like norepinephrine. Norepinephrine is your Levophed or epinephrine. You could also use phenylephrine. Atropine could be given to block that vagal parasympathetic stimulation causing the bradycardia. Remember, atropine is a anticholinergic, so it is like the sympathetic system. They may do transcutaneous or transvenous pacing if the bradycardia is symptomatic, and if it's hypotension, it's symptomatic. If the primary condition cannot be improved, continued cardiovascular support is necessary to maintain adequate systemic perfusion. Oh gosh, I didn't even change the slide. Sorry, guys. Whoops. Okay, so complications, obviously the hypoperfusion can lead to multi-system organ failure. So that's what we want to try to make sure does not happen. But we have to get our cardiac output improved and our blood pressure improved. So interventions. With neurogenic shock, it's important to raise the head of the bed slowly in a systematic manner. So when you have this loss of systemic vasomotor tone, raising the head of the patient's bed can cause orthostatic hypotension because of the inability of the peripheral blood vessels to constrict with this position change. So orthostatic hypotension can cause, in this instance, hemodynamic instability. So they raise the head of the bed like 10 to 15 degrees per hour, very slow. We could put in arterial lines to manage or monitor our hemodynamic needs, give IV fluids. We talked about crystalloids, medications. We talked about our sympathomimetic agents like phenylephrine and norepinephrine. We may have to pace our patients. We talked about atropine, and VTE prophylaxis. Okay, that's it, guys. That's the end of the voiceover.